Okay, are you able to see the screen?
Yes, yes.
Yes, okay.
It's okay.
Okay, thank you. I think I got the difficult end of it. It's because my topic was challenges in diagnosing back and leg pain from chiropractic perspective. So it's a huge perspective in terms of properly diagnosing or misdiagnosing conditions. So it is a bit descriptive. So please excuse me on that. It is a problem.
Can you make it a whole page?
Yeah.
Whole screen? Yeah.
Okay. Yeah.
Mm-hmm.
Okay. So it is a problem with multiple faces, which I think it deserves a multidisciplinary approach. And so my presentation will be, again, it's descriptive and it's progressive towards trying to identify a proper solution to the diagnostic problems that we actually see in diagnosing back pain and associated leg pain. So under each subject topic, we can essentially, from the top of our heads, we can count tens of conditions and essentially add up to 50, 60, even 70 different conditions that can cause back pain and associated lower back pain. So from this, I would like to concentrate on mechanical conditions. And out of the mechanical conditions, I would like to first just go over lumbar facetogenic pain. So we have studies that show lumbar facet mediated pain is a common cause of chronic low back pain. The orthopedic evaluation of the lumbar facet pain is largely based on exclusion or exclusion of other conditions or other conditions that may be causing low back pain. So I wanted to see what the risk factors were for lumbar facetogenic pain. So there are degenerative disc disease, having high BMI, degenerative joint disease, inflammatory arthritis, and repetitive microtrauma, and that was touched upon. It could be in just patient's lifestyle, or it could be athletics, just accumulated microtrauma. When I looked at the referral patterns for the facetogenic pain, you can easily see that obviously it involves paraspinal musculature. It could easily be mistaken for myospasms or myogenic pain patterns. But then you also see its referral pattern into the gluteal region. And anything at or below level of L3, L4 facets, you can essentially have in varying percentages, see the referral going down the leg, staying above the knee, or going down the leg, going below the knee. We can easily mimic any type of radiculopathy or other conditions that I will try to touch upon. And as well as having an inguinal or groin area referral just as well. The other topic I wanted to, most common conditions that both spine specialists actually see is discogenic. So according to Shayota and Hancock, up to 40% of patients experiencing back pain may suffer from discogenic pain. So I wanted to see the risk factors, again, for discogenic pain. They're very similar to facetogenic. So again, overweight, smoking, and we'll see how smoking actually affects the general, not as a risk factor, but also as a causative factor. Type 2 diabetes, physical demanding lifestyles, or sitting or extended periods, again, accumulating microtraumas. And men are actually more inclined than women and having underlying connective tissue disorders. So, well, I wanted to see how prevalent the discogenic pain is. According to Constantino and Lingawi et al., well, they say it's only less than 1% of the patients with suspected LDH that have actually serious pathology. So I wanted to, according to public health issues and various publications that's been coming about since the bone and joint decade, since the year 2000, obviously chronic low back pain is a recurrent condition. It's not just one episode. So I wanted to see what the risk factors were in recurrent lumbar disc herniation. Well, if a person is having a spinal disc surgery younger than 4 years of age, they are more inclined to have their reoperation in their 4th and 5th decades of their life. Again, gender, men are more prevalent. Again, having high BMI, smoking, diabetes, activities of daily living, whether it be occupational or sedentary lifestyle, and or just having an unconditioned body, or a body that has lost its conditioning. When I look at the referral patterns for the discogenic pain, it almost perfectly overlaps with facet issues. So again, you have axial pain patterns. It could be in the lumbosacral area, just lateralizing off to the paraspinals. You could have referral going down the leg, staying above the knee or below the knee, or both. Research shows that a specific single dermatomal level is actually very uncommon. However, if we do have a specific dermatomal presentation, that it is highly specific of lumbar disc herniation. So having that unspecificity in terms of referral from a lumbar disc herniation and facet, it can easily be mistaken for, I just handpicked 4 conditions. So the first one we actually looked at was your lumbar facet referral patterns, but it can easily be mistaken for sacroiliac, having similar groin referral, having similar somewhat of axial presentation, referral to the gluteal, upper leg, and even to some degree to the lower leg below the knee. And the funny thing is, when I looked into myofascial pain patterns, something that is more simplistic in nature, but maybe more difficult to pick up on, is trigger points. Just out of this confusing chart that I have, I just want to look at, on your reading left, the second picture on the bottom, gluteus minimus, having a trigger point on the gluteal minimus muscle can perfectly mimic a referral going down as if it's a L5-S1 radiculopathy issue. So this is one of the problems, I think, that we see in diagnosing low back issues, just because there's just so much overlap, and obviously piriformis and a whole bunch of other conditions are left out of this presentation. I wanted to see what the correlation was with using MRIs, CAT scans, and X-rays. And obviously, imaging is medically justifiable for those that worsen during conservative care, who fail to respond to conservative care, or having red flags and signs and symptoms initially, even just way before during their case history and presentation. So I came across some interesting studies dating back to 2013, and it will progress up to 2022. A study that was done in University of California showing that MRI use or utilization was medically inappropriate over 50%. Another study in 2020 where clinical guidelines recommend that non-specific low back pain with or without radiating symptoms, not complicated by red flag conditions, should be treated with conservative therapy, and that MRI is not indicated in the first 6 weeks of onset. However, studies have found that 26 to 44% of MRI use is not guideline concordant. Moving on forward, slightly getting into the psychosocial approach of patient care, there's a study that came out and published in Neurospine Journal in 2021, when the reports of the MRIs were actually shared with the patient. Patient had catastrophizing reflections on it. However, instead of reporting on the images, if the clinical findings were reported to the patient, saying that, well, you have a joint here that is restricted, or you have a disc problem, or it's pinching on a nerve, or you have a muscle problem, just keeping it in the lay language for the patient, all of a sudden the outcome measures drastically improved. I wanted to see, because within chiropractic, X-rays are historically been utilized significantly. So I wanted to see what was going on over there. And it's a fairly new publication, 2022. It's a scoping review that shows that X-rays are significantly overutilized within chiropractic, as well as MRIs within the greater medical profession. And so moving on from MRIs just going into this, I just like to concentrate on the age group of 20 to 50. I would say that's where we see a lot of our patients. And I just like to concentrate on the very first one on top, this disc degeneration. This study shows that 37% of 20-year-olders are actually asymptomatic, though MRI findings show disc degeneration. And each decade, the asymptomatic percentage significantly increases. And by the time we get up to age 50, so if we overlook case history, if we overlook physical assessment, if we just take an MRI, and we're apt to see 80% degeneration, yet they are asymptomatic. So to really concentrate and focus on finding the pain-producing structures within low back has become incredibly difficult, yet we have so many different conditions that perfectly overlap with each other. Moving on into not just the biomedical approach, but also looking at biopsychosocial. From a conservative perspective, we see a lot of patient fear and avoidance versus maybe a lot less it would be within the secondary or tertiary healthcare settings as surgeons, as you essentially save lives in the surgery rooms. But we actually, in the primary setting, we hear a lot of the depression and the fear of avoidance and the anxieties and all that bit that a patient brings into the clinic. So the British Medical Journal defines evidence-based as it's the application of best available research to clinical care, which requires integration of evidence. So we have our evidence, the clinical expertise. Well, the clinician has the expertise, but how much do the primary, the secondary, or the tertiary healthcare providers actually calculate in the patient values, which essentially are going to make up the psychosocial and the environmental factors into their pain perception and their reflection on what they think they're feeling. So this, yeah, moving on from there, I wanted to see what the evidence was on psychogenic conditions and psychosocial factors in patients' perception of pain. So psychosocial factors are important in musculoskeletal pain management because they can affect pain intensity and disability. Negative thoughts can negatively influence the perception of pain, according to a study back in 2009. Moving on forward, in 2018, more recent publication, it's a systemic review. 83% of the articles reported within this review showed association between psychosocial factors and acute pain becoming chronic. 29% demonstrated that depression was a possible predictor, and 35% of the studies found fear of avoidance to be associated with chronicity of the pain. Interestingly, there's a meta-analysis of cross-sectional study that 30% of smokers will likely to suffer more low back pain and will likely to become more addicted to use of opioids than non-smokers. So this slide and then the predecessor, it actually just overcomplicates having multiple conditions perfectly almost overlapping on one area of the body, with utilization of diagnostics and risk factors essentially becoming almost as a causative effect of having back pain. So this is, I think, to me, is one of the most detrimental factor that will go into making the diagnosis of low back pain problematic. Us chiropractors are to be, from my perspective, are to be blamed significantly, because to us, everything is a restricted joint. So we just want to manipulate it, we want to move it, and then be done with it. However, when we actually look at this systemic review, and it's fairly new, overall in the greater medical profession, associations between cognitive biases, they reach up to 36.5% to 77%. If we just go by this percentage, it's very likely that all of us in this room will actually misdiagnose with our initial entry to the patient and then potentially correct our diagnosis. To fix this problem in this complex world and with increased complexity of a patient, these are the solutions that, as a chiropractor and from a chiropractic professional perspective, I offer. Having inter and intra-professional collaboration, better communication between professionals, multiple conditions with very similar clinical presentation, though back pain seems to be very more simple than diagnosing a cancer and things in those lines as sinister is concerned. But I think we may be taking it to a point where we're undermining its complexity and having unjustifiable or medically unjustifiable use of advanced diagnostics. And at least in conservative patient care, and before I actually took the platform, I could not catch Dr. Sait. He actually touched upon it from a medical legal perspective. Being able to justify everything that we do and not considering the patient's values and wants and needs in terms of what they feel like they need for their body. And obviously the very last bit, which is my big one, is not having clinical biases. That's my presentation. Thank you for listening. And I will unshare my...
Thank you very much, Dr. Mustafa, for your presentation. Is there any question for Dr. Mustafa or comment?
Great talk indeed. I must thank Mustafa for his great talk. Actually, we don't look at those items like behavioral problems, the psychological and biological and social problems of the patients. We ignore sometimes because we look everything as if we will operate, we will make surgeries. So this webinar has focused on this, and then I thank all the speakers for that.
Dr. Naderi.
Yes, it's very good talk, and we learned something from chiropractic expert point of view. The main difference is a chiropractic, they can get cervical spine, lumbar, thoracic spine, MRI, and then decide to do chiropractic in any part of the body. But most of neurosurgeons in these cases get only lumbar spine MRI. This is so because, as Dr. Zileli said, when we find something and if it is symptomatic, we operate it. But you do not operate, you apply chiropractic techniques. The main problem in these cases is overlapping. This is very important. But I think in most cases, I get lumbar spine and sacroiliac MRI, both in these cases. And these MRIs can reveal any other pathologies in the sacrum, sacroiliac joint, and in the pelvis as well. If needed, we can add pelvic MRI to see coxarthrosis and the upper part of the femur. To me, the differential diagnosis is very important, and what I have seen so far is lumbar oriented pain are not, there is no tenderness actually. But in all other sacroiliac and piriformis or coxarthrosis or other problems related to the hip, there is local tendernesses. This is very important. Therefore, actually, I recommend to my colleagues to examine patients not only in the supine position, but also in the prone position, and because you can reveal facet joint pain also, a local tenderness in facet joint pain in other problems, and this may help diagnosis, but overlapping still is a problem in these cases. We cannot hear. Any other question?
Do you wish
Other
to comment something? Ömer?
May I ask a question for Mustafa? I wonder your decision-making options for sacroiliac joint. How you evaluate the patient, and how are you making a decision-making? How you plan the treatment for sacroiliac joint as a chiropractitioner?
Yeah. So
because in Izmir, I saw too much patient. We followed together, and I know there is a huge impairments of the from the pain from your treatment. What's your opinion?
Yeah.
How you decide? How you make a decision for treatment?
yes. So obviously, the patient presentation and listening to the patient's subjective complaints, and more than listening, but trying to make sense, is very important. So taking a thorough case history is very vital. After having taken the case history, obviously we'll follow through with a focused assessment, focused examination on the differentials that we actually come up with, whether it be facet or sacroiliac or disc or piriformis or gluteal tendinopathy or what have you. And as we go through our tests, we will rely on the specificity and the reliability of the orthopedic tests that we're using to see if we have positive positives or false positives, so we can correlate them with the subjective findings of the patient. Putting 2 and 2 together, it essentially, literally, you can make almost a determinate diagnosis, like 80%. And if you don't have any red flags, then traditionally, and also legally in some parts of the world and jurisdiction-wise, we can't really refer for MRIs, or in some parts of the world, you can. So you can make use of the diagnostics to confirm your findings or exclude your differentials. And the treatment end of it is, so in Izmir, my relationship with you, Ömer, actually, and Mehmet Zileli has always been very respectful, so I appreciate that. And so as a chiropractor, when I fell short within my knowledge and practical skills, I had you for me to refer my patient to. So that was a perfect multidisciplinary approach. And sometimes the patient actually went through surgery, and sometimes the patient came back to me and the patient is saying, well, the surgeon said, just go back to Mustafa, he'll take care of it. And so it was actually a perfect, setting to practice that multidisciplinary practice. And the actual application, in a lot of the times, we do use different approaches of manipulative techniques. Sometimes they're just manual, hands-on. Sometimes they're table-assisted. Sometimes they're instrument-assisted manipulative techniques, depending on the varying degree of the pain the patient comes in with. I had one patient when I was in Izmir who I barely put my hands on to do any application. And I had a really close friend who's an anesthesiologist. she came in and she delivered a intra-articular injection that calmed the patient down, calmed the area down, and then we were able to proceed with manipulation on the local anesthesia, and then the follow-up for if I'm not mistaken, 6 months or so, she was asymptomatic from that there on. So that's essentially how I did it and how we teach our future chiropractors to do, and hopefully they do it. So that's basically it.
Okay, thank you.
Thank you.
Okay.
Mehdi, there is one question in the text. Some cervical spondylotic patients complain back pain. What is the reason of that? Is it funicular or tract pain? Do you have an experience? The question is this.
Was that to me?
I don't know. Anybody?
Well, actually, the rate of tandem spinal stenosis is 20%. I mean, in 20% of cases with lumbar spinal stenosis, there is also cervical spondylotic cervical spine stenosis as well. And also, this is same for cases with cervical spinal stenosis. In these cases also, there may be lumbar spinal stenosis in 20%. Therefore, actually, we operated in these cases from cervical and the lumbar spine in some cases. If cervical spine is much more severe, we need to operate first cervical spine. In some cases, there may be also thoracic spine stenosis as well. This is so because degeneration doesn't select only one part of the spine.
Yeah.
Degeneration is a problem of the aging. It starts in the knee, in the hip, and then lumbar spine and cervical spine. All the body can experience this problem.
Yeah, I think and probably we can conclude this panel as there is no good correlation of the films, MR images, and symptoms of the patient. And there is currently an overuse of the films, and there is a neglectance of good examinations. Can we tell this? Mustafa, what do you think?
Yeah. I mean, of course, I'm not going to oppose you. It's
Ömer?
I would also add in the clinical cognitive bias as one of my favorite ones. We're one to blame for it as well as chiropractors.
Yes. We can conclude this session, Zileli. The low back pain and radicular pain are frequent symptoms, but not all originate from spine. There is many different diagnoses, differential diagnoses. The percentage of from spine is less than 1%, and most of pain are non-specific, low back pain and non-specific. We should do the correct diagnosis. We should examine the patient, do the tests, do the radiological investigation, and the essential to do the correct diagnosis of the pain to give the adequate treatment, I think.
Okay. I also thank all the speakers and all both moderators
Yes.
for their valuable contributions.
Thank you very much. Thank you very much for
Good
your
night.
participation. All.
Bye-bye.
Thank you. Bye.
Bye.
Goodbye.
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 Bye. Have a nice day.